Hello, I'm Darryl Baker, one of the vascular surgeons here at the Royal Free Hospital, and I also work at UCLH at Queen Square. And I'm going to talk for about 20 minutes on the management of carotid endarterectomy. The word carotid comes from the Greek to plunge into deep sleep. And that was the event which would happen when you squeezed on the carotid artery. The talk will be divided into 6 separate stages. Firstly, the indications and the procedure involved in carotid endarterectomy. Then discussion on the type of anesthetic that can be used, what monitoring equipment is usually expected, how the theatre is set up, how to maintain status quo during the procedure, and then what happens when there are complications. Now, why do we do a carotid endarterectomy? It's because the burden of stroke is so high. There are almost 14 million new strokes every year, of which almost 90% are ischemic. And that will result in 2.7 million people dying from an ischemic stroke in the world each year. Now, of all strokes, the carotid is the cause in about 15%. And this is because there's thickening or atherosclerotic plaque develop at the bifurcation, which then breaks off, and as it ulcerates, little clots, little thrombi throw up into the brain. And then that causes the occlusions of the brain, blood vessels, and a stroke. A carotid endarterectomy, which is peeling out this narrowing, has been shown when it's a tight stenosis to significantly reduce the likelihood of a further stroke over medical therapy. And if it's a moderate stenosis, it also does so, but to not an extent. You'll notice that this work is old, but continues to be of value. Another thing to note is that when the carotid endarterectomy is done as soon after a non-disabling stroke as possible, the greatest benefit is made. Here, in a tight stenosis, if it's done within 2 weeks, there's anything up to 32% relative risk reduction. And it gets less as time goes on. These bar figures here are for the benefit from a moderate stenosis. I'm going to mention now the basic outline of the surgical procedure. It's interesting to note that Mr. Escott, this gentleman here with his back to us, was the first gentleman to undertake the procedure in the 1950s at St. Mary's Hospital. The incision is either up and down vertically along the anterior border of sternocleidomastoid or across the muscle, as shown on our left. The vessels are exposed, as we can see on the left-hand side. You can see the internal and external carotid arteries coming off the common carotid artery, and the hypoglossal nerve sitting just up the top up there, coming across there. The vessels are clamped, opened up, and the endarterectomy, the tissue is removed, just peeled out, leaving a nice clean area here on completion on the third slide. And then the vessel is closed using a patch, nowadays almost always bovine pericardium. On the local anesthetic, in about 20% of cases, a shunt or just a tube is needed to keep the patient neurologically stable. And under general anesthetic, we tend to use a shunt all the time. The reason why this is important to know is that the patients can have altered cardiovascular and neurological symptoms during this procedure. And also the surgeons can become a little twitch themselves, as the tube is not always easy to put in and can fall out and can rip the vessel wall. I'd like now to just consider the general views of whether to do a general anesthetic or local anesthetic for the procedure. Both techniques are extensively used, and these are the assumed benefits and disadvantages of each. The local anesthetic, you can evaluate whether the patient is conscious or not and having neurological stroke at the time. It means that the shunt doesn't have to be used. which is a benefit because it's technically easier, although there's no evidence this reduces stroke. The disadvantages of local anesthetic is if the procedure is long, the anesthesia can start to wear off. The patient becomes agitated because they get aches and pains elsewhere. It requires excellent teamwork coordination, having nurses who are unfamiliar, having a block that's not as good as one would want, and having anesthetists and surgeons who don't work as a team all the time can make it more challenging. Also, if it's necessary to convert to a general anesthetic, this can be traumatic. The benefits of a general anesthetic are outlined below here. What does the data show? Well, there is actually a Cochrane database review of several randomized controlled trials comparing GA with LA, and they all demonstrate, or meta-analysis, that neither technique, general anesthetic or regional local anesthetic, provides a benefit with regards to stroke, death rate, myocardial infarction rate, respiratory complications, and length of stay. So in summary, we have to always pick what is best for the patient and what we're familiar with using. I'd like to move now on to the third part, which is the monitoring equipment. It's important to be able to monitor the cardiovascular system closely during the procedure, and therefore always, as usual, a continuous ECG is present, and the intra-arterial blood pressure monitoring is vital. Certain units will use a transesophageal echo during general anesthesia, especially if there's severe coronary artery disease. In general, we do not do this here. A urinary catheter is also important to monitor cardiovascular output, but is vital, often vital, during local anesthetic, because the sensation of needing to pass water can be very, very severe. And you'll find when the patient wakes up, if we haven't put a catheter in, the blood pressure goes through the roof because of the bladder pressure. There's a lot of talk in the literature about different ways of doing cerebral monitoring. And the most common ones are the use of stump pressure, that is a back pressure into the common carotid artery, where you put it's in the top right-hand side, put the needle into the vessel and get a pulse wave back. And if it's over 50, then you don't use a shunt. Near-infrared cranial perfusion monitoring that we have been using also gives some idea of the amount of oxygenation, but again is not clear what to do. Transcranial Doppler monitors the through the temporal bone, monitors the middle cerebral artery, and this will show whether the shunt is working and whether there's adequate backflow, but again does not show hypoxia to the brain. So although there are a lot of different techniques, and I've only shown you the three most common ones used at present, there is no clear indication to use one over the other, and possibly no clear benefits by using one or the other. I want to move next on to the theatre flanché. In other words, how do we set the theatre up? Now, the positioning of the anesthetic equipment, and therefore yourselves, in relationship to the head and neck is easy enough under general anesthetic. Probably stay as far away from the head and neck as possible. But during local anesthetic, you need to be able to talk to the patient and monitor them throughout, also see your blood pressure and other monitors, and to protect the airways. And by that, I mean the temptation for the surgeon is forever to put their elbows onto the face and therefore stop the person from breathing. So having a chair near the patient, being able to talk to them, being able to care for them, is a vital part of looking after the patient. Positioning the head and neck is also important. Usually it's best supine with a minor degree of neck extension. This can be done by elevating the shoulders with a sandbag and using a head ring. But care needs to be taken because the cervical spinal arthritis often makes the neck very stiff, and we don't want to snap the neck. overextension also has the effect of making retraction difficult and exposure more difficult. Slight head up, and therefore splitting the table so that the patient doesn't slip off, will improve venous and lymphatic drainage for the head and makes the operation easier. So a good idea to always put a pillow under the knees, because it stops aching when they wake up after the general anesthetic and aching during the procedure under local. Temperature control is an area that is steeped in the history of carotid endarterectomy. And a passive hypothermia is thought to increase cerebral ischemic time, although there's no evidence for this. Some units still let there be passive hypothermia. And you can see this picture on the right-hand side, which is when first carotid endarterectomy was done at St. Mary's. The patient was actually put in around ice bags to bring the temperature right down. Today, the overall aim is with most general anesthetics, with most anesthesia, is to try and keep normothermic. Under general anesthetic, a warming blanket is often needed, but under local anesthetic, due to the autonomic response, the patient is often a little anxious, sweaty, and a fan is needed. Although recently the fan has been removed because it's believed to be an infection control risk. So the anesthetist sometimes ends up fanning the patient with the consent form. Carrying on with the Fouché, although what we've really got to do is to make sure that, and this is the surgeon's responsibility, make sure that the correct images are available and open all the time, because with the modern CT angiograms, we can get a good impression of where the vessel is, how far up we need to go, and what we're doing. Some DVT prophylaxis, tend to wear TED stockings unless there's significant peripheral vascular disease. Under general anesthetic, patients will have Flowtron boots, but you do need to remember that as we're doing them so quickly after their stroke event, they're almost always on dual antiplatelet therapy, and we do give 5,000 units of heparin post-clamping. Just as a note, restarting the heparin DVT prophylaxis post-op, we tend to leave it for 24 hours, check the patient is okay, and then start low molecular heparin. Everybody gets the appropriate antibiotics just prior to incision. This is just a little background here showing how we drape the patient for carotid endarterectomy. The neck is draped, the airways and the tubings are protected. There are 4 small drapes placed around the neck, as you can see on the far top right, and then an aniline dressing put over it and then covered. This is just so you know what the heck the surgeons are trying to do. Now we start the operation, and obviously keeping the patient asleep is important, and I leave that with you because that's your area of expertise, and I don't interfere with that. But for me, the most important thing is the cardiovascular status. It's really vital to keep the patient at a correct blood pressure. There's a lot of articles and discussion about what is the correct blood pressure, but we tend to use a preoperative systolic blood pressure, allowing it to drift anything up to 20 millimeters of mercury above pre-op levels during cross-clamping. But if it does get above 160 or definitely 180, then reduce the blood pressure. And this is usually with labetalol, little infusions. Why is this important? Well, why do the patients get hypertension with them? Usually it's their underlying hypertension and they haven't taken their medications. Surgical stress, and we're talking about the patient's hypertension, not the surgeon's. Surgical manipulation of the carotid body, and when you're extubating, a rapid recovery rather than a deep recovery can make the blood pressure fluctuate. What are the effects of this? Not only myocardial ischemia, but cerebral reperfusion injury, cerebral hemorrhage, bleeding from the wound site. And hypotension, you can tell me more about this than I can, but the general anesthetics tend to have vasodilators and reduce the pressure more. Hypovolemia can occur, although this should be minimal. Bradycardia does occur at different times of the operation, especially when working around the bifurcation. And this is important to watch and make sure the surgeons tell you that, because not only do you give medications at your end, but local anesthetic just under the, around the bifurcation will reverse the bradycardia. And the effects of a hypertension are outlined there at the bottom: hyperperfusion, thrombosis, myocardial infarction. The next thing that is also quite important is to try and obtain hemostasis before the end of the operation. And the reason for this is really vital, because a hematoma and then a return to theatre does increase the risk of stroke and death. And you've got to remember that the carotid patients are at a higher risk than most. You've given them 5,000 units of unfractionated heparin before cross-clamping. They're on the dual antiplatelet therapy, and sometimes the operation can be a difficult neck, full stop. At the Royal Free, we can use a TEG to determine platelet inhibition, and that will also help guide us. We've got this pathway on our right side where we wait for 5–10 minutes to make sure we've got meticulous control of the bleeding. The light compression, then half-dose protamine to reverse the heparin. Then, if that doesn't work, a gram of tranexamic acid, and then after that, we use platelet transfusion. And hopefully with that, we can reduce our return to theatre. In fact, we have from about 7% to less than 1% in the last 200 carotids. Finally, what I'd like to do is talk about what keeps you back after the operation. And there are two main things that do that before you hand the patient over to recovery or to the high dependency unit, and that is a stroke. This is the most terrible, devastating thing if the patient has a stroke during the procedure as identified on the local anesthetic or on waking. And the actions that are needed from the team are really to continue to maintain strict blood pressure control. Blood pressure can go up and down all over the place. Also, if the patient is struggling, they may need to be re-intubated. The patient will be taken to CT, and if we're in that limbo state where we're not 100% sure we need an HDU bed or an ITU bed, that will need to be arranged as they go down to CT. I put this last thing down as the local, the patient should not be transferred to HASU. That's the high hyperacute stroke unit down at Queen Square. This is a medical ward. They don't look at wounds or do anything. So send a patient who is within an hour of post-operation, who's had a devastating stroke, down to a unit that can't manage vascular or anesthetic problems is not the right step. We involve them in the management of the drug management in the high dependency, but not transfer them. The second thing is bleeding. Now, there's a popular understanding of bleeding, and this is taken from Gray's Anatomy. You know, the anaesthetist chatting away for the patient at the top, thing breaks down, and everybody realizes it's a problem. This is very obvious, and it's clear that it needs to be done. There are sometimes when it's the more subtle and it's not clear. So we tend to try and use the shout airway risk tool, which will gradually pick it up. Not necessarily immediately on waking, but definitely in recovery and up on the ward. And the reason why it's important to be aware of what this could mean if there's bleeding is you know what surgeons are like, they don't always think they think it'll all settle down, so they will usually send the patient for a CT scan, and that will therefore mean having to take the patient down to CT scan. We're lucky that in our units we can get the CT within a few minutes. Need to maintain tight blood pressure control. Anxiety, wriggling around is going to push it up. Blood loss is going to push it down. Discuss the reversal of the heparin, which should need to be taken. Order blood, and then if there's any need to take the patient back to theatre, they will need to be done under general anesthetic, which again just makes it more challenging. Any other causes for to stay back, like respiratory airway problems, I'll leave with you. Myocardial infarct, we tend to get the cardiologists involved. All our outcome data are submitted to a national vascular registry where both the surgeons and anaesthetists are recorded and the individual data are published. This is for last year's figures, where you can see us in red, and you can see the percentage survival and the number of procedures done. And that's where we fit in there. So this is, although they say it's each year, it is over a 2-3 year period. Thank you very much. If you have any questions or any problems or any interest in carotid surgery, just email me or ring me at any time. Thanks a lot.